You're listening to Case by Case, the podcast where medicine meets real-world practice, one clinical case at a time. Brought to you by a continuing education company, this series brings you front-row access to compelling case studies recorded live at top-tier CME conferences across the country. Each episode, we dive into a single, real-life medical case presented and discussed by leading experts in the field. It's medical education, elevated, engaging, and deeply relevant to today's practice. This is Case by Case. Let's begin.
So we'll dive into case 2, which I think will help reinforce some of this. This is a woman that I met actually first at Johns Hopkins Hospital when she was there with a recurrent MI, but then followed up with me in lipid clinic. So she's now following up, but her ASCVD history includes MI, and she had a single vessel PCI 5 years previously. And then when I first met her, she had a hospitalization for a type 1N STEMI and unfortunately had progression of coronary disease and required bypass surgery. She had a really striking risk factor profile, including the hyperlipidemia, but also diabetes, hypertension, and rheumatoid arthritis. Her family history was notable for premature ASCVD. She had a father with an MI at age 57 with hyperlipidemia, a brother who died of an MI at age 50 with hyperlipidemia, and a paternal uncle who died of an MI in his 40s. And, as we talked about, FH is underdiagnosed, and, she had been in the medical system for many years, but was not formally diagnosed with a genetic lipid disorder, and nor had she had physical exam findings noted. But we don't do this it's more of an outpatient thing, but she was there inpatient, and we did her physical exam. She had clear bilateral corneal arcus and thickened Achilles tendons. These are just things that don't typically get looked for in clinical practice. And then if you looked all the way back, this is not her lipid panel now. She's now already on some lipid treatment. But if you look back, her untreated LDL was 307. Wow. So quite striking. So which of the following lipid disorders does this patient have? I know we've talked about this quite a bit today. Is this familial dysbeta-lipoproteinemia, familial hypercholesterolemia, familial combined hyperlipidemia, or none of the above? All right, so we have most saying B, which is what I believe to be the correct answer. She had a very high baseline LDL. She has this striking family history of premature disease. She personally had premature disease. She has physical exam findings, the xanthomas of familial hypercholesterolemia. Familial combined refers to also a genetic lipid disorder where you have elevation in triglycerides, triglyceride-rich remnant lipoproteins in addition to the LDL. She actually had a normal triglyceride level, which is classic for FH. Now, this can be tricky because in modern clinical practice with obesity and prediabetes, diabetes, there can be this superimposed triglyceride elevation in a patient with FH. But in her case, that was not present on her prior historic untreated levels. So she fits best with familial hypercholesterolemia and familial dysbeta-lipoproteinemia, also known as type 3, is something we didn't talk really about today, and that's an elevation in triglyceride-rich remnants, particularly IDL, that's also atherogenic, but really she is screaming familial hypercholesterolemia. Is there anything you want to add?
Only that it doesn't surprise me she went this long without diagnosis.
Yeah.
I had a fellow many years ago who did an analysis just of our outpatient population at NYU. And we looked at patients who met the Dutch Lipid Clinic Network score, and then went back and looked at the diagnosis, and then even did chart reviews to see how many of the patients had simply been told they had a genetic lipid disorder, not even FH in the chart. And at that time, it was 1%.
Wow.
Now, the number bandied about now is about 10 to 15% of these patients are being diagnosed, which still means 85% are not being told they have FH.
Yeah.
And it's just unbelievable to me.
It is.
Yeah.
It is. I've seen patients who have gone for a heart transplant due to underlying ischemic cardiomyopathy, due to underlying FH, that made it all the way past heart transplant without actually getting diagnosed with FH. It's amazing how, despite high levels of medical attention. This doesn't get diagnosed. So that's why I think we've talked about it as much today. Like, this really is out there, and we all need to help.
And the frequency of FH, I don't think I listed it. It's, when we were training, or at least when I was training, I'm older than you, we were told it was 1 in 500.
Yeah.
But it's probably closer to 1 in 250.
Right.
And in my neck of the woods in New York, it's probably closer to 1 in 150 because of populations, called founder populations, that we see more of in New York. So that's, think about how many days does it take you to see 200 patients? We're all seeing these patients, just not picking them up.
We're all seeing it. I mean, you even can be at a hotel like this and be standing at the elevator. You might see someone and see corneal arcus and be like, have you checked your cholesterol? Like, it's out there. There's over 1 million people. And again, most have not been diagnosed yet. So let's all be looking for it. The simplest criteria are the AHA criteria, which again is basically high LDL and family history, think FH. In the cases we presented, that was very present. But if you have access to genetic testing, that's a good thing to offer. The most common mutations are in the LDL receptor, those what you think of as the garbage trucks in the liver to clear out LDL are just, there's not enough of them. They're not working well. That's the most common mutation, but you can also have mutations in ApoB, which interacts with the LDL receptors, or PCSK9 because of its role in leading LDL receptors to be broken down. I know you like these AHA criteria. They're nice and simple.
This was published by Sam Giddings, who's a pediatrician. I want to ask a question. How many people in the room have kids under the age of 11? How many have had your kids' cholesterol checked? So the recommendations is every child should have their cholesterol checked between ages 9 and 11. Doesn't get done. Doesn't get done in pediatric classes. And if there's a family history of heart disease or high cholesterol, it should be done at age 2. And it's just not getting done. Sorry.
You have a child with less than 11?
Not now, but
Oh, I saw you raise your...
mine certainly didn't get checked
just-
by our pediatrician.
Right, you had to ask for it.
Yeah, and I asked for it. And that's
Well, I'll tell you an interesting story. So I forget the first year I saw this gentleman at the VA in Charleston, and he has a very famous nephew who was a very accomplished wide receiver for the Miami Dolphins from North Charleston, South Carolina. And he came to me, but he was also being seen by the orthopedic clinic, and he had Achilles deposits of familial hypercholesterolemia. He had an LDL of 220. So I put him on niacin, and I up-titrated him to 3 grams of niacin, tolerated it beautifully. I put him on bile acid resins, 30 grams a day of powder, no tablets, tolerated it fantastically. And I forget if it was in 1985 when lovastatin came out. And I put him on lovastatin and got him up to 40. I forgot what the ceiling dose of lovastatin was. I got his LDL down to, believe it or not, I think it was 80. And over time, he no longer was going to go for surgery to the orthopedic clinic because his Achilles tendonitis was resolving. And Robert lived, I think he died when he was 84. And, it was an amazing story. But my point is, the drugs we had, we could still use. And there were people out there that would tolerate them. So,
Absolutely.
That's why I always say, and maybe I'm wrong, but I think good clinicians can get more people to stay on their medicine if they work closely with them and really, are passionate and, get the family involved, et cetera,
And once you find a regimen that works, it tends to just work long term. It should become very boring because the medicines are tolerated and the LDL will be similar from year to year. I mean, those are that's a nice situation to be in. We have patients at our lipid clinic, like you're describing, that start on statins as soon as they came out, and then things have gotten better over time, and their levels have been controlled for a long time, and they're just super consistent from year to year.
Yeah.
And by the way, the FH patients have contributed substantially because they're often the first population in which new drugs are then tested, and then it gets expanded to other indications. So they've really helped advance what we have for many.
Their histories teach us so much because they have been seen by other people and then finally somebody makes the diagnosis. Yeah.
So this slide is just, again, the Dutch criteria. If you want to go a little bit, fancier than the AHA criteria. This takes into account the a little more detailed family history, the clinical history of premature disease, the physical exam findings, and then stratifies based on LDL level elevations. The cases that this first case would have been in sort of the second category, giving you 3 points. The second case we just discussed would have been in the third category, giving you 5 points. If you then, let's say, for the case we just discussed, you get 5 points for that. Then the tendon xanthomas give you 6 points. That's 11 points already. That's above the definite threshold for FH. But many of the patients end up in categories that are in the possible or probable. And so that's where genetic testing can be helpful in making a definitive diagnosis. But I think we should have a tendency to just make the clinical diagnosis based on simple AHA criteria. If you have access to more sophisticated techniques, that's great. Okay, so we have a simple question. I think this is reinforcing prior ones. Is this patient very high risk by the guidelines?
Yeah.
Boom, 100%.
Beautiful.
Okay, we can move on. All right, and this just reinforces what we already discussed about. It's basically a history of recurrent ASCVD events or one event with multiple high-risk conditions. This particular patient we just discussed had recurrent events, but also had multiple high-risk conditions, so meets the very high-risk criteria in multiple ways. And as Dr. Underwood noted, the vast majority of patients are very high risk, and you can almost assume this. This might be helpful to write in your notes for PCSK9 approval, to just be very clear that someone meets guideline-based very high-risk criteria. Okay, so the patient's on atorva 80, maxed out on that, ezetimibe 10, goes to cardiac rehab, which is fantastic. That's another area where it's important treatment and program that's underutilized in care. They've been doing that for 3 months, and now has the lipid panel showing an LDL of 127. So as noted, her triglycerides were normal as they had been. The main issue is the LDL still being elevated. So what do we do next? PCSK9, fibrate, bempedoic acid, or omega-3? All right, great. 97% for PCSK9 inhibitor, which I think is the best option. I mean, the LDL is still 127. This is someone we want to try to get below 55. That's a long shot when we're starting where we are. This is the challenge in people that start with such high baseline levels. So this patient may end up going on both A and C, but I think the best next step is the PCSK9 inhibitor. Now, we didn't give the context. If she said she has some crazy fear of needles and can't do any, then that would change things. But we didn't give that context, and most patients are okay with injectable therapy. So that's why I think A is the best next choice, but she could end up taking, to get her lower is better, and she may not get to 55 with a PCSK9. So I think then you may end up adding the fixed dose combination pill of Nexlizet that brings both the ezetimibe and the bempedoic acid. The fibrate wouldn't make sense. We don't have good data for ASCVD risk reduction in the modern era with fibrates. The latest trial of pemafibrate didn't pan out, and her triglycerides were normal to begin with. And then omega-3 fatty acid therapy, something like Visipa, there is controversial data there around ASCVD risk reduction, but again, she doesn't meet criteria, didn't have an elevated triglyceride level.
In your practices that need modulation of PCSK9, what % of people are either on a monoclonal antibody versus inclisiran?
I would tell you in my practice, there are more on monoclonals, but that's just because that's what I started with first, and they're doing well, and they don't want to change it. So of my newer patients now who I start, I offer them the option. For some people, the idea of every 6-month dosing is appealing. I find like a bunch of patients with FH who are off in college, coming home every 6 months to get an injection versus storing it in a fraternity refrigerator.
Yeah.
It's not appealing,
Yeah.
and there are some people that just want to do it. So I let them know about it. The efficacy seems to be similar, but I also tell them we don't have outcome data yet with glycerin.
Right. I say the same thing. We don't have outcome data, and but it can be a good option for some people for the adherence reason that you mentioned. Insurers may though have a criteria that you need to first fail the monoclonals anyway before. So that is another population in which we will use inclisiran, is those that have failed both evolocumab and alirocumab, either due to lack of the response that we wanted to get, and this is uncommon, by the way, but it does happen, or they had some perceived side effects and want to try something different. But those are generally challenging patients. I would put the percentage of inclisiran for my overall PCSK9 use in the single-digit percentages.
Because the buy and build in an academic medical center, you guys wouldn't buy and build, would you?
We do, but it was a lot of effort to get that up and running, and even then, my lipid clinic team sometimes finds it easier to work with the external infusion, or they call it infusion center. It's really they're injecting the therapy, but these external centers might be closer to the patient's home, or they're just quicker at processing things than our internal team is. So my nurse sometimes will say, I'd rather just work with
I also find that I'm similar to you in that actually for us, our institution has chosen not to add it in as an offered therapeutic, but Mount Sinai does. Bob Rosenson does it there. But what I find is that when I start inclisiran, the patient goes off to an alternative infusion center, I kind of lose track of them. Whereas if I'm prescribing the monoclonal to their pharmacy, I'm seeing the prior auths, I just have much more of a feel of what's going on with the patient. I think the LDL lowering is pretty similar, and the safety data is similar. And so if a patient expresses adherence issues, I think it's better. And I think at Bellevue, we're actually trying to get it approved. It's hard because the patient population has very diverse insurance resources, but that's a group of patients where we have a lot of barriers to adherence, and it would really improve our ability to get patients on a drug like that.
I would tell you, patients that can avoid an infusion center will have a more cost-effective type of care. Infusion centers charge.
It's an interesting model. I mean, I understand why they developed the model from a financial perspective, but it changes flow of practice. I think that's what you're referring to. And I found it's a little more inconvenient to do it. That's just been my personal practice.
For sure.
Other people love it. I have colleagues that love it.
I think people can come into an office, never even see the clinician. Somebody gives them a Q6 month, they may get a lab, and they go home. And the insurance will cover it. So I don't know.
So we'll see. Yeah, the reality is that evolocumab is by far and large, when we say PCSK9 inhibitor, the one that's being used. But I do, alirocumab is used in a smaller percentage than inclisiran.
Used 2 weeks.
Even smaller percentage. So we'll see as the clinical outcome trial data come out and things get more adopted in guidelines. We'll see. There'll probably be a continued shift, but on the smaller scale.
I think the exciting part of this is that there's some really interesting data with these drugs that if you give a monthly dose, because there used to be a monthly dose of evolocumab, 420, and if you give that at the time of the MI in the hospital, by day three, their lipids are optimized. By day three. So, you think about what happens when patients leave an institution. Let's say they have their MI out of town, and by the time they get back to see their cardiologist and their primary care clinician, and then get on these medications, it's months, and that's when the next event happens. So this data around early administration of aggressive LDL lowering in the hospital, I think, is the next big change.
There should be, I hope, a metric of some sort of time to LDL goal. There was a lot of progress in acute MI care when they had the metric of door to balloon time, but then it's about prevention time, right? I think you said time is plaque, time is events. So I do hope that we'll have more urgency around hitting these goals in that post-acute care setting.
So there's no longer a 420 of evolocumab?
No, they've stopped it.
It's every 2 weeks now?
Yeah.
Oh my goodness. Okay.
So, but a lot of patients do really well with that schedule. I think fine patients are highly adherent. This is originally, it was only available through specialty pharmacy. Now a lot of the retail pharmacies have it, so patients can pick it up in the community or it gets delivered to their home, and it works out, I think, really well for a lot of people. This is reinforcing that in patients with clinical ASCVD at very high risk, they can be considered for PCSK9 inhibitors. So just would try to document that terminology because it may make or break the insurance approval. This is the key flow chart that is going to be updated in the next guidelines, but has at the bottom in a very high-risk patient after the high-intensity statin therapy and ezetimibe that PCSK9 can be considered. And this was talking about thresholds of LDL 70 or more, but then we've moved on to the 2022 consensus pathway with less than 55, which I think will be cemented in the next guidelines. And in patients, the case example we gave hit on the very high risk scenario, but also the severe hypercholesterolemia scenario where the baseline LDL was 190 or more, which is also a scenario that supports PCSK9 inhibitor use. So so as we wanted to do, the patient gets on the PCSK9. What do we think her LDL is going to be? What is it going to be too low when we're starting from this level? And so this is to reinforce what we were talking about, some of the data that we have, that this is a time to go as aggressively low as possible. The safety data are really reassuring here, whether you look at diabetes or cataracts or hemorrhagic stroke, you can go down to levels less than 20 and we don't see any increase in these types of adverse effects in Fourier. We just see a benefit that the lower we go, the more we're reducing plaque and reducing cardiovascular events. So this is all reinforcing that, and that in a very high-risk patient like this, we would go to an LDL below 55, non-HDL below 85, and ApoB, this says less than 60 from our NLA statement, and I think we can just, for simplicity, use the goal of less than 55 as well. There's a nice review paper from one of our colleagues, Anne-Marie Navarre and her team, where they showed that at those lower levels, if you look at the clinical trials, the on-treatment ApoB and LDL line up pretty well, so that an equivalent level should work quite well. And for example, in the Fourier trial, they got well below both an LDL and an ApoB of less than 55, supporting that. So that's where I would go with this patient. So she ended up with an LDL of 48, which is actually quite a nice response. And at that point, it would be, I think, a bit hard to get additional prior authorization through for bempedoic acid, but this is a situation where maybe you could consider then doing more testing with an ApoB, and if that came back high, that could justify even further add-on. But she's obviously in a much better place than she was to begin with. Other thoughts on this?
No, I think this is a great example of how you can get aggressive with your LDL lowering. And I agree with you about the low LDL. One of the things I always tell my patients is that the majority of the cholesterol that's traversing in your bloodstream is not being trafficked inside lipoprotein particles. It's not an LDL or VLDL or IDL, because I get calls, my patient's LDL is -2 in the middle of the night, and it's an emergency and the lab wakes me up. I remind people that at least 50% of the cholesterol is on the surface of red blood cells. And it's exchanged on and off red blood cells to lipoprotein particles and to end organs that need additional cholesterol. So you have so much extra cholesterol. The brain makes its own cholesterol. It's an independent corporation. LDL does not cross the blood-brain barrier. The only lipoprotein particle that does is HDL. So your LDL can be 0, and I'm fine with it. It doesn't matter. And that's, I always say to my patients, I'm sure you do this too, I always say, don't let anyone else stop your medications, because sometimes they'll go to a cardiologist that's not interested in lipids, or they'll see their endocrinologist, and the next thing I know, their statin's been reduced, they're off their ezetimibe, and it gets me nuts. So low LDL is fine.
Yes, yeah, completely agree. This is a challenge, and it's tough for patients when they start getting those discordant messages. It can be an issue of
Well, that's where your formula comes in great.
Yeah.
A lot of people think of that for triglycerides, high triglycerides, but it's also great for low LDL.
It does reduce those negative numbers and the calls in the middle of the night.
I said, that can't really be.
Right.
Thanks for watching. If you found this discussion valuable, be sure to like, subscribe, and hit the bell so you never miss a new episode. To explore upcoming CME conferences and earn credits while staying at the forefront of medicine, visit cmemeeting.org. Until next time, keep learning, case by case.